Walk into any intensive care unit or cardiac operating room, and you will see it scrolling across the monitor, a blue, undulating line. For decades, clinicians have treated central venous pressure as a simple fuel gauge, a static number used to determine if a patient needs more intravenous fluid. But that number is a mathematical abstraction. The trace itself is a high-fidelity mechanical transducer of the right heart. Because there are no valves in the superior or inferior vena cava, every contraction, relaxation, and structural shift within the right atrium and right ventricle transmits retrograde up the venous column, registering directly at the catheter tip. To accurately read this trace, we have to map its normal physiological waveform, predict its pathological variations, define its systemic determinants, and isolate the reasons why it fails to reliably predict fluid responsiveness. Mastering CVP mechanics separates the accurate diagnosis of structural heart failure from the dangerous mismanagement of volume resuscitation. This synchronized diagram aligns the electrocardiogram on top, right ventricular pressure in the middle, and central venous pressure on the bottom. By tracking these three together alongside the cardiac cycle, we can isolate the mechanical origin of every single deflection. The cycle begins with atrial systole. Following the P wave on the ECG, the right atrium contracts to push the final 20 to 30% of blood volume into the ventricle. That muscular squeeze pushes blood back against the venous column, registering on the CVP monitor as the prominent A wave. Next, the electrical signal hits the ventricles, marked by the QRS complex. The right ventricle begins isovolumetric contraction. As pressure in the ventricle suddenly spikes, the tricuspid valve is forced tightly shut and bulges upward into the right atrium. That brief mechanical intrusion creates the smaller C wave. Then comes the steep X descent. Two forces drive this pressure drop. First, the atrium is relaxing. Second, the right ventricle is violently contracting and shortening, physically dragging the entire tricuspid fibrous ring downward. This stretches the right atrium, plunging its internal pressure. While the ventricle is still ejecting blood into the pulmonary artery, systemic venous return continues pouring into the right atrium. Because the tricuspid valve is still closed, blood piles up against it. This steady accumulation builds atrial pressure, forming the V wave, peaking just after the T wave. Finally, ventricular pressure drops below atrial pressure. The tricuspid valve snaps open. The pooled blood rapidly empties passively into the right ventricle. This rapid outflow drops atrial pressure back to baseline, creating the Y descent. The normal CVP trace is a sequential map of structural right heart movement. Its morphological shape communicates far more physiological data than its absolute numerical value. Because the waveform is mechanically bound to the cardiac cycle, we can isolate structural failure by identifying when specific mechanical events deviate from the established Wiggers model. In atrial fibrillation, electrical chaos eliminates coordinated atrial systole. With no organized contraction, the P waves disappear from the ECG, and the A wave vanishes from the CVP trace. The X descent is also blunted. If the tricuspid valve fails to seal properly, ventricular systole will force a jet of high-pressure blood backward into the right atrium. In severe tricuspid regurgitation, this regurgitant volume obliterates the normal pressure drop of the X descent. Instead, the C and V waves merge together, forming a massive early pressure spike known as a giant CV wave. In complete heart block or AV dissociation, the electrical pathways fail entirely. The atria and ventricles begin beating independently of one another at different rates. Inevitably, the right atrium will attempt to contract precisely while the right ventricle is in systole. The atrium squeezes its entire volume against a closed tricuspid valve, resulting in an enormous pressure spike called a Cannon A wave. These morphological anomalies provide an immediate diagnostic reading. A single glance at the waveform identifies right heart failure, valvular incompetence, or arrhythmias. If the morphology tells the structural story, what does the absolute numerical value mean? The mean CVP represents the equilibrium point between the blood returning to the heart from the systemic circulation and the right ventricle's ability to pump that blood forward. This diagram illustrates the systemic variables dictating that central pressure. The value can increase due to a massive influx of venous return, such as acute hypervolemia from rapid fluid administration or heart failure-induced fluid retention. But volume is not the only driver. The pressure will also rise if venous compliance decreases. Heightened sympathetic tone or the administration of vasoconstrictor drugs will shrink the venous reservoir, driving central pressure up without adding more fluid. Conversely, if the right ventricle fails, or if it encounters massive pulmonary resistance from a large pulmonary embolism, forward flow bottlenecks. Blood backs up into the venous circulation, elevating the CVP. Finally, external physical compression alters the reading. Cardiac tamponade, constrictive pericarditis, or the application of positive end expiratory pressure during mechanical ventilation will physically compress the system, artificially raising the measured CVP. Because volume overload, pump failure, venous constriction, and external compression all elevate the pressure reading, the absolute number alone fails to identify the underlying physiological dysfunction. For decades, standard clinical practice dictated measuring central venous pressure to guide intravenous fluid administration, often targeting an arbitrary static value of 8 to 12 millimeters of mercury. The foundational error is the assumption that pressure is a reliable proxy for volume. It is not. CVP is a measurement of pressure, not a measurement of intravascular volume. This graph maps ventricular volume on the x-axis against central venous pressure on the y-axis. The relationship between the two is dictated by a nonlinear ventricular compliance curve. In a stiff, poorly compliant heart, perhaps due to ischemia or hypertrophy, the curve rises steeply. A seemingly normal CVP reading on the y-axis maps to an end diastolic volume on the x-axis that is dangerously low. Contrast that with a highly compliant, chronically dilated heart. The compliance curve flattens out. Now, that exact same normal CVP pressure maps to severe volume overload. Extensive clinical data shows that isolated CVP readings fall into a massive statistical gray zone. Within this band, absolute pressure tells the clinician nothing useful about where the patient sits on the Starling curve, or if they will respond to a fluid bolus. Utilizing a static pressure metric to guide dynamic volume resuscitation is physiologically flawed and statistically dangerous. Modern intensive care has moved away from static metrics. The standard for predicting fluid responsiveness now relies on dynamic indices. Clinicians look at variables like pulse pressure variation and stroke pressure variation. These dynamic measurements calculate how the cyclic shifts in intrathoracic pressure during mechanical ventilation temporarily alter venous return. The magnitude of these variations accurately predicts if the system will benefit from volume expansion. The enduring value of the central venous catheter lies in its role as a real-time diagnostic record of the mechanical integrity of the right heart and tricuspid valve. By understanding the exact physiological origins of the A, C, and V waves, clinicians bypass the abstract numbers to identify structural pathology as it happens. Absolute mastery of cardiovascular physiology requires abandoning arbitrary static targets. True hemodynamic assessment demands a rigorous understanding of the underlying mechanics.